So first of all, if we look to the useful biomarkers that we can need for metastatic or locally advanced unresectable breast cancer that are hormone receptor positive, HER2 negative, we have several therapeutic options. We already discussed that. So we may need germline BRCA. We know that those patients are usually more frequently BRCA2 mutated, but they can also be BRCA1 for PARP inhibitors. They can be HER2 low. So for ER positive, HER2 negative, it's almost half of those patients that can have an HER2 low status. The mutation of PIK3CA, so we discussed that a lot, and we have seen also that we can have co-alteration of PIK3CA, but also of HER2 low, but also of BRCA. I'm going to cover more in detail the ESR1 mutations. They can also harbor in the tumor the HER2 mutations, especially enriched in lobular carcinoma, up to 15%, 20% in some cases. Extremely rare in breast cancer, and even more exceptional, the NTRK gene fusions, but they can also be a therapeutic option. The immunotherapy biomarker are not very frequently present in those type of cancer. MSI high, extremely rare in breast cancer. TMB high, we have foundation medicine data showing that it can be high, especially it was a surprise in lobular carcinoma, 10%. And we don't have any indication of PD-L1 inhibitors, and no validated biomarker so far for CD46 inhibitors, with the exception of some preliminary data, but we cannot use them in routine, showing that the intrinsic basal subtype tumors are highly resistant to CD46 inhibitors with very early relapses, but we don't use that in routine. So ESR1 mutation is a mutation that is induced by treatment. It's extremely exceptional in naive breast cancer, less than 1% of breast cancer. And if you have a de novo metastatic breast cancer, is less than 1%. And you see progressively an increase in ESR1 mutation when breast cancer are treated, especially by adjuvant or neoadjuvant aromatase inhibitors. So going around 5%. And in metastatic breast cancer previously treated by aromatase inhibitors, we find those mutations in 20 to 40% of the cases. And when we have a mutation, the receptor has a change in conformation with a constitutively active conformation that allows the fixation of elacestrant. And it's also triggering in the breast cancer cells a proliferation, survival, migration, and resistance to aromatase inhibitors. So this is really an oncogenic pathway and a resistance pathway. So we have a pooling question. What is the most common type of ESR1 mutation in metastatic luminal tumors, or ESR1 gene alteration in metastatic luminal tumors previously treated with aromatase inhibitors? So ESR1 epigenetic modification, ESR1 amplification, ESR1 point mutation, or ESR1 fusion. Okay, so the answer is ESR1 point mutation. That is the most frequent alteration that we have for the patient previously treated by aromatase inhibitors. You can see that on this slide. So we can have those alterations in 20 to 30, and in some papers also 40% of metastatic luminal tumors. The loss of ESR1 expression can be found at different stage of breast cancer. It's epigenetic modification, and we don't know exactly why do we have those epigenetic modification. We can have some level of ESR1 amplification that could be found, and also rarely some ESR1 gene fusions. But what is really interesting for the treatment, and especially for elacestrant, is ESR1 point mutations. We know also that patients with ESR1 mutated breast cancer have a poorer outcome. It has been shown in many different studies. And I really insist on the fact that this is something that you have to test when you want to treat the patient. So after the resistance to the first-line therapy, because it's a new mutation, it's really absent or extremely infrequent in early breast cancer, or even at when the patient recurs just after aromatase inhibitor. So this is something that you cannot go back to the primary tumor. That is not the case, for instance, for PIK3CA alterations that are constitutive in breast cancer. So you can find them already in the primary tumor. It's not the case with ESR1 mutation. It's a new oncogenic pathway. It's really a resistance pathway to our aromatase inhibitors. So let's go back to the EMERALD trial. In this trial, 47.8% of the patients had a detectable ESR1 mutation. As you know, they had previously received endocrine therapy, and almost half of them 2 lines of endocrine therapy. Some of them had visceral metastases, also 68.2. And what is important is that we have a companion test that was used in the EMERALD trial. The companion test is the Guardant 360 CDX assay. So it's an assay, it's a liquid biopsy assay that is looking to, as the number says, many other genes, 360, with 100% level of detection with a very high sensitivity. So when you have more than 0.5 allelic fraction, so really it's one of the most sensitive assay on the market. And even when you have very, very low level, you still have 88.3 sensitivity. So this assay is in US the companion diagnostic test for elacestrant. When we look to the guidelines for ESR1 testing, so I will start with a pooling question. When would you test for ESR1 mutation upon diagnosis after first line of endocrine therapy only, at recurrence or progression on endocrine therapy, or all the above? Okay, so the majority of you have responded at recurrence or progression on endocrine therapy. We are going to see what are the guidelines right now. So we had early update of ASCO 2023 guidelines for ESR1 testing, and ASCO guidelines recommend testing at recurrence or progression on endocrine therapy given with or without CD46 inhibitors. So this is very clear, recurrence or progression. How the liquid biopsy is the recommended test by ESMO guidelines, by ASCO. We had a trial in France with Palbo also, where we look at another test that is called digital droplet PCR, also liquid biopsy, and CCN also recommend NGS or PCR blood, but all those guidelines were published before the ASCO rapid guidelines for ESR1 testing. So if now we look at the advantage of this approach, so we have for breast cancer, we can of course look at tissue biopsy. Liquid biopsy has several advantages. It's little invasive and dynamic. It captures tissue heterogeneity. It requires a very sensitive technique because the DNA that is shedded released by the tumor in the blood comes from dead cells, but you also have plenty of DNA from plenty of normal cells that die in our body because of tissue renewal. So we need to have extremely sensitive techniques to be able to capture those low level of tumor DNA. And so there is a problem of sensitivity. That's why you require a sensitive technique. If you have a negative result on a liquid biopsy in this setting of resistance to endocrine therapy, and if you want to see whether you have ESR1 mutation, you can repeat the technique a few months later, because maybe it's the beginning of that and it's a limit of sensitivity. So how long will it take to retest? Do you want to retest after 2 or 4 months or wait for the evolution under the second line? This could be discussed in the multidisciplinary tumor boards. So I've shown you here different techniques with different level of sensitivity. The Sanger sequencing technique is a technique that is not suitable for liquid biopsy, because you really need to have a very pure sample. So it was a historical technology we use for tissue. Real-time PCR or NGS will be with a limit of detection of 1% of ctDNA of tumor DNA among all the circulating DNA. And using the other technology like digital droplet PCR or very specific NGS will really help you to capture those very low amount, 0.01%. Of limit of detection. That's what we have in the Guardant, for instance, assay. So this is very, very important when you ask for a test, to know what type of test will be provided to you. How will you send a sample for this liquid biopsy detection? So the ESR1 mutation research will be requested by the oncologist on liquid biopsy with the addition of an order form. So you have two options. You use the classical EDTA tubes for blood, and if you have a laboratory of biology on site, because within 6 hours you need to have a centrifugation. And then those centrifugates, because we will look at ctDNA in the serum, not in the pellets, in the serum, and it can be tested right away, or it can be freezed and tested later on the molecular biology platform with DNA extraction and PCR, digital droplet PCR or NGS technique. And for that, you need a special shipment on a dry ice bed by a carrier, and you will have the result rather quickly. It could be done in 2 to 15 days, but it depends where you send and what is the volume of the laboratory. Sometimes you have a failure, so you can also look on tissue, but for that, you need to have the tissue of the metastasis after the recurrence under the progression under the first line treatment. So it's not the primary metastatic biopsy, it will be the biopsy at the moment you want to have it. So paraffin block can be sent by the pathology structure to a department of biopathology or molecular biology, where we look on the slides, where do we have tissue, we select the area for molecular biology, we do the extraction, and we can do the PCR and the NGS technology. But I really insist, because we really need for that to have the biopsy just at the moment where we have the relapse, not the biopsy of the primary tumor and not the biopsy at the first diagnosis of metastasis. So it's much more complicated. That's why liquid biopsy is really the best option and the recommended option. So in conclusion, ESR1 mutation is really something that now we need to have for our patients with ER positive, HER2 negative metastatic breast cancer. Those alterations are mainly in the ligand binding domain. We have 12 hotspot mutations, so it's not very complicated to design in the lab if you don't have access to the Guardant test. And we have two mutations that are more frequent, the D538G and the Y537S that are more frequent. They are point mutations. So as I said, between 25-40%, around 30%. And those alterations are more frequent than rearrangement and amplification. But for elacestrant, it's really point mutations that are required for the treatment. The presence of an ESR1 mutation seems to be both prognosis and an indicator of a worse prognosis and predictive, resistance to aromatase inhibitors, and sensitivity to some SERDs like elacestrant. This mutation search is possible without repeated biopsy of a metastatic site. And this research can be performed reliably by liquid biopsy at recurrence or progression on or after endocrine therapy plus minus CD4/6 inhibitors. And with that, I think that we have now time for discussion.
Thank you so much, Frédérique. That was an incredible overview and really does show how complex this testing is. Maybe you could just start off and tell us, what are you actually doing in France? How are you guys doing testing there?
So in France, unfortunately, we don't have access to PIK3CA inhibitors, but we had an early access. So we arranged at this time the liquid biopsy for breast cancer. So all the circuits were already organized. So in my hospital, we have a custom panel of liquid biopsy for breast cancer. And we have requests from the oncology team when the patient has a progression. So, but we were well organized with that because of PIK3CA alterations.
Okay, no, that's great. How about you, Aditya? How are you guys doing testing at MGH? When are you ordering, for example, liquid biopsy, and what type of liquid biopsy are you ordering?
Good question. In general, we are strong believers in liquid biopsies, so we tend to get plasma-based genotyping. For patients with hormone receptor positive MBC, usually in the second line setting, so if a patient has disease progression on AI plus CDK4/6, that's the time we get our first liquid biopsy. But then we also do serial genotyping because some of the alterations like ESR1 are acquired. And as was discussed previously, you can miss them initially on, but in the second or third time, when you do serial genotyping, you can pick it up.
And are you ordering serial tests in your patients? So for example, if you get one test after progression on CDK4, and then they go on to a line of endocrine-based therapy and progress on that, do you then get another assay? Like, are you doing it after each line of progression on endocrine-based treatment?
Somewhat, yes. Not with every line. So if someone has progression on, say, Xeloda, we would not do it because we would not expect the mutation profile to change much. But if a patient is getting targeted therapy, which includes endocrine therapy, we do get repeat testing. So if patient gets AI CDK4/6 first test and say goes on fulvestrant alpelisib, and then 9 months later has disease progression, we would get it again at that time.
Okay. And Frédérique, is that?
Yes, I would just like to add that with ESR1, in almost half of the cases, we can see polyclonal ESR1 mutation. So not only one, but 2 or 3 ESR1, because it's a resistance mutation. So it's very different from an oncogenic mutation that, like PIK3CA, that is here from the beginning. But it doesn't seem to have any impact on the response to SERDs right now, but it's something that occurs.
Oh, thank you. That's really important to know. One question that came up was, if it's difficult to see rare clonal mutations in metastatic breast cancer, is there any real clinical implication for treatment knowing this? I don't know, Frédérique, what you think about that.
Well, I think it's different. Sometimes the level of the presence of mutation is low because it depends on the shedding of the tumor. So it depends on how many tumor cells die. So it's very different from a tissue where we see an allelic frequency and a percentage because we have selected the tissue and we can say this alteration is present in 70% or 80% of the tumor cells. That is very different when the alteration is present in 1 or 2%, because you will say, do I need to have a targeted therapy for 1 or 2% of an alteration? In a liquid biopsy, you don't cover that, because you don't know how many tumor DNA you have. So that's why it's relevant for this type of targeted alterations, and you will see very quickly also if you have a response.